Hi, everyone. We'll go ahead and get started. On behalf of the National Alliance for HIV Education and Workforce Development, also known as NAHUD, I would like to welcome you to our monthly webinar series. My name is Liz Lazo, and I am joined by my colleague, Ashley Johnson. Before we begin, I want to review some housekeeping items. We invite you to use the chat to engage with your fellow attendees. Ashley has added questions so that you can get to know each other and who is participating today. So for today's session, it will be recorded. The recording and a PDF of the presentation will be added as a resource on the NAHUD website about a day or two after today's session. The link will also be included in the post-webinar email that you will receive tomorrow. If at any time during the session you have questions for the speaker, we ask that you use the Q&A pod, and he will address that at the end of his presentation. So before I introduce our speaker, I'd like to go ahead and just give a little background introduction to NAHUD. If you're not familiar with us, we are a membership organization of 8 regional and 2 national AIDS education and training centers, also the AATCs. Established in 2010, NAHUD supports the AATCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations to promote and educate on the work of the AATC program. So since 2019, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder. ORN provides free resources and technical assistance locally in communities across the United States and its territories. So we invite you to visit the ORN website for more information and or to submit a request for technical assistance. So we value and welcome your feedback on today's webinar. We will include a link to the evaluation towards the end of the session, and it will also be included in that post-webinar email. We ask that you complete it within the next 2 weeks. If you are requesting CE credit, so CME, CNE, or social work continuing education credit, or a certificate of attendance, you will need to complete the evaluation. And something just to share is that we do use that feedback as we think about the next sessions in our series, and we provide that feedback with our speakers, and I know they find that to be very helpful. So please complete the evaluation. So at this time, it is my pleasure to introduce today's speaker, Drew Gibson, who is the Director of Advocacy, is a nationally renowned harm reduction and HIV policy expert with more than a decade of experience both working in and advocating for organizations who serve people living with HIV and people who use drugs. In his role at AIDS United, Drew leads on a wide range of federal, state, and local efforts to increase access to syringe services programs, the SSPs, and other forms of harm reduction throughout the United States, using AIDS United's unique national and local resources to highlight the importance of increased government and private sector support for harm reduction. Drew also works with members of AIDS United's Public Policy Committee, Harm Reduction Futures Fund grantees, AIDS United's Capacity Building Assistance Program, and other collaborative organizations to provide guidance around policy and funding matters affecting syringe access, HIV and viral hepatitis prevention and treatment, overdose prevention, access to medically assisted treatment, supportive housing, safer consumption sites, and intersecting forms of criminalizations. Drew is experienced at delivering training and technical assistance concerning the intersection of HIV service provision, drug user healthcare, and public health policy at the federal and state level to clients within both the private and public sectors. So without further ado, I will go ahead and pass it to Drew. Thank you so much for joining us today.
Thanks so much, Liz, and apologies if I sent that intro to you. That was a small novel. Thanks for reading it out. I am going to put up the presentation on the screen, and then we can get started. Let's see here. Just like I accidentally started on the questions page, but we can. And is that looking good for at least Ashley and Liz? Is that looking ready?
Yes.
Wonderful. So as Liz mentioned, my name is Drew Gibson, he, him pronouns, Director of Advocacy at AIDS United. Today's presentation is titled Law and Disorder, How the War on Drugs Impacts Drug User Health. Just stating at the outset that I have no actual or potential conflict of interest in relation to this presentation. I forgot to do an intro slide for me, but you can see my face. Liz gave a very comprehensive biography. I mean, the word expert is thrown around a lot. I just have a number of years working in DC on federal harm reduction policy, working with folks at the state level on harm reduction policy, and some experience doing programmatic work, and lived experience as well. But it's really a pleasure to be here, and hopefully y'all can get something out of this presentation. At the end, please ask me any question that you have related even tangentially to the materials I'm covering. Hopefully we can answer it and maybe get a discussion going. But without further ado, going over the learning objectives. The main things I want to try and get across over the next hour or so is to help you become familiar with sort of the historic in the US, to gain some strategies for combating stigma and effectively engaging with people who use drugs within your work and also in your personal lives, and also to feel comfortable with HIV and drug user health advocacy approaches that hopefully you can get more involved at the state, local, and even federal level to the degree that your positions allow. So wanted to start out with sort of a crash course in US drug policy. The TLDR version it's bad. Going into a little bit more depth, it's bad and pretty much uniformly racist. It's not listed on the page, but going to late 1800s, U.S. drug policy has been driven by xenophobia and racism. In the 1860s and 70s, anti-Chinese sentiment in California in the wake of the gold rush led to a number of anti-opium laws that sort of continued with the Chinese Exclusion Act of 1882. And then bled into the Opium Exclusion Act of 1909, which was specifically targeting Asian Americans or China Americans specifically, who smoked opium as opposed to imbibing it in other ways that didn't have a racial bias to them. The Harrison Narcotics Act was passed in large part due to incendiary racist tropes again around Chinese Americans, but also around Black Americans, and cocaine use and spurring racist fears in white lawmakers and the public. The reason we have the word marijuana and use it so often now is because of racism. In the 1920s and 30s, folks in the government stopped using the term cannabis and started using marijuana to increase sort of anti-Mexican sentiment and build up fear that way, which led to the Marijuana Tax Act of 1937. And it kind of goes on from there. The Controlled Substances Act, while not overtly racist, it mainly was a way of codifying some of the things that were outlined in the Harrison Narcotics Act and creating the modern drug scheduling system that we have today. But also it was sort of the signature piece of the Nixon administration's war on drugs. As you'll be able to see in the quote that's on the right side of the screen, one of the president's advisors, John Ehrlichman, said after the fact that they knew they couldn't make it illegal to be either against the war, Vietnam War, or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. Did we know we were lying about the drugs? Of course we did. And that is U.S. drug policy in a nutshell. It is rarely, if ever, been driven by by science or by a concern for people who use drugs or those who love them. It has been mainly used as a policymaking tool for essentially controlling and subjugating non-white portions of the country. And the last thing that we'll just point out is the 1986, the Anti-Drug Abuse Act of 1986, as some of y'all might remember, came at the height of the crack cocaine panic, the death of basketball player Len Bias. I guess it was in 85 or maybe even 86, sort of spurred on this public fear campaign that led to mandatory minimums, the incredibly, unjustifiable disparity between sentencing for powder cocaine and crack cocaine that disproportionately impacted Black and Latinx communities. This is, I think, what a lot of us sort of associate with the war on drugs because it's so fresh in our history. But all of these things are taken from a similar cloth. So we're at the modern day. It's a really interesting time to be involved in drug policy, interesting in good ways and interesting in bad ways. We've seen tremendous progress in the past 5 years. Measure 110 in Oregon, which decriminalized all drugs in the state and then used a lot of the money that was going towards prohibition and law enforcement, towards recovery services, treatment, and harm reduction is just getting started. Of course, the existence of Measure 110 and the decriminalization efforts in Oregon have sort of sponsored a massive backlash. There's a campaign right now in Oregon to repeal Measure 110, which is led by a lot of really powerful interests, including Phil Knight, CEO of Nike. But I think sort of one of the things that harm reductionists are coming to grips with now is that when you have policy wins, you also make yourself a pretty large target, and your opposition will try and use that against you. So I think that's certainly something that we're aware of, and trying to work with communities to understand that going back to the war on drugs and to a punitive prohibitionist approach to drug policy is not going to get us where we want to go and will actually make things worse. Another big victory recently was the first U.S. overdose prevention centers that were established in New York City. On Point has 2 locations in New York, one in Harlem, one in Lower Manhattan. I've been to the facilities; they're absolutely amazing. When I was fresh out of college, I worked at a Boys and Girls Club. The vibe there was more like an adult clubhouse than it was a medical facility. They had the room that was set aside for safer injecting, and they had a smaller room for safer smoking. But for the large part, it was just a large room with people, hanging out, talking, watching TV. That there were services upstairs for seeing a physician, getting massages, acupuncture, I think, was one of the services they offered. It was a really, really cool thing to experience, and hopefully something that we can see replicated elsewhere. Rhode Island recently passed legislation that was signed into law by the governor that will allow for a safer consumption site in their state, and using state opioid settlement fund money, which is incredible. And we've seen similar pushes in San Francisco, Chicago, and Philadelphia to varying degrees of success. But hopefully this is something that continues and is really promising. Want to just sort of bring up and you may have seen this in your work or just watching the news, that there have been a lot of talks recently about raising new mandatory minimums for sentences, and also death by distribution laws. And I think for us as folks who work directly with people who use drugs, who work with people living with and affected by HIV, it's really important to remember how potentially destructive death by distribution laws are. And the death by distribution law, if you're not familiar, it is a form of legislation that essentially says that an individual who sells or provides someone with a drug who then overdoses off of said drug can be held legally responsible for their death and convicted of murder. And that is, as I go to sort of this look at recent trends in arrests around drug offenses, that is incredibly harmful when it comes to working with the community. And we can talk a little bit about that on a later slide when we talk more about HIV criminalization laws, which I think have a very similar effect. But when we talk about sort of the state of drug policy in America, I think we because of all of the very deserved coverage and plaudits that a lot of new harm reduction interventions get, we can be led into thinking that that is still the predominant modality for addressing drug use in the US, and that is simply just not the case. For the most part, drug possession related arrests in the US have stayed stagnant. As you see on the Pew Charitable Trust chart on the right, while a number of drug related crimes have significantly been reduced, at least during the 2010s, there's been a negligible reduction in drug-related possession arrests. Similarly, you see that 1 in 4 prison admissions in the U.S. As of 2019 were drug offenses. This is still astronomically high and speaks to the degree to which the war on drugs is still firmly entrenched in our approach to the overdose crisis in this country, and how much more work we have to do to have a more public health centered approach. So, mentioned HIV criminalization as something that might be related to death by distribution laws and to drug policy in general. I think any sort of policy wherein having knowledge about yourself or in which authorities have knowledge about your actions can lead to arrest and imprisonment is a deterrent towards folks engaging with systems, right? So we've seen this with HIV criminalization laws. Really, if you are someone who you suspect you're living with HIV or you may have contracted HIV or you're worried you may have, the most surefire way to ensure that you're not criminally liable in a state that criminalizes HIV transmission is to not get tested. If you don't know your status, then you can't be arrested for knowingly transmitting HIV to someone else. And that is a huge problem as we work towards ending the HIV epidemic in the US. And that is really predicated on getting everyone who is at risk tested whenever possible, and providing environments that are judgment-free, stigma-free, and where people feel comfortable talking to their provider, whether it's a physician, whether it's a nurse, social worker, addiction counselor, whoever it is. These sorts of laws really hurt those approaches that require trust and client engagement. It's the same thing that we're seeing where we have death by distribution laws that are preempting Good Samaritan laws in states, right? Like if I'm someone who uses drugs and I am with a friend or a loved one and they overdose, and I'm in a state that has death by distribution law, I have to think in that moment, okay, am I willing to risk being locked away for the rest of my life or not the rest of my life, but at least for a long period of time, if I call the authorities, if I call 911 to help revive my friend or loved one and they don't make it, right? Like I think the idea that calling 911 for help needs to be like a complex decision around weighing if someone's going to be incarcerated or not is ridiculous, and really harms our efforts to prevent overdose in this country, and also to establish trust between people who use drugs and folks who are trying earnestly to provide services to them. I also think that we're seeing similar things happen with anti-trans laws, and sort of general homophobia in hampering patient-provider relationships. I think if we've seen anything from the last maybe 2-3 years even, at the state level, it's that trans youth, and trans individuals in general have been targeted to a degree that we have not seen maybe ever, just because of the increased visibility of trans individuals and trans rights prior to these attacks. But we're seeing funding being attacked. We are seeing providers in states like Florida that are being forced to choose between, retaining their accreditation or providing needed hormone therapy and other services for trans folks. So all of these things are ways in which the provider client relationship is being disrupted by really horrific and ill-informed policy. And I think it's a continuum when you think about drug policy, HIV criminalization, and a lot of the anti-LGBTQ laws that we're seeing crop up across the country. If you leave this presentation with just one thing, I hope it is that this equation. If you have punitive drug laws and you stigmatize people who use drugs, then people are going to be incentivized to withhold information from their medical providers and other sources of help. They're going to have a really justified fear of seeking medical care, and that trust with their providers is going to be completely eroded. There have been several stories in the past few years exploring this phenomenon, especially with the resurgence or the emergence of xylazine as a chief additive in the U.S. drug supply. But it is really shocking to see the number of people who use drugs who would quite literally rather have one of their limbs rot off or even die than go seek medical care for drug use related wounds. And the power of that fear and the disdain and shame that they feel often in seeking out providers is something that is entirely on the provider end. This is something that is within our control as people who serve these communities, people that are members of healthcare systems. Like, this is on us. And every single person that doesn't seek out medical care because of fear or shame or stigma is really reflective on our ability to provide the services that are needed. We can't maybe do as much around punitive drug laws. People like myself and other advocates certainly will continue pushing against them. But I think as someone that provides services to people who use drugs and who works with other folks who may harbor stigmas towards this community, it is entirely within our capacity to educate folks and to make sure that we have a welcoming environment for people who use drugs, and that they feel like they can come to us for care. Sound like a broken record, but trust really is everything. Nothing's more important for the provider person who uses drugs relationship than maintaining trust. Especially when it comes to discussing their drug use or anything else that could result in their arrest or imprisonment. I think it's natural for us to want folks we work with to be completely transparent and to let us into their lives so we can best serve them. But a lot of times, people aren't willing to do that because they know that the consequences could be dire if the person that they're working with doesn't have their best interest in heart or will report them. So I really think that that's another thing that maybe it takes discussing things with your supervisors, to see what your organization's policy is around disclosure of drug use or other behaviors. And if this is something where like maybe you have to be very purposeful about stating ahead of time to a client that like, hey, these are the rules of my organization. If I'm informed about this, then like I need to talk to someone about it. So please do not discuss specifics of use here, because I mean, my hands are tied. I wish it was otherwise. But just establishing that bottom line for folks. So at the very least, you're being open and honest with them, and hopefully you can build trust that way. But for the most part, focusing on preventing dehumanization and dismissal of the needs of people who use drugs in healthcare settings is paramount. Wanted to briefly just touch on a topic that I think it seems kind of self-explanatory, but it honestly is not adhered to in a lot of medical settings. And that's that drug use is a part of people's lives. It doesn't define who they are, and it doesn't define why they're coming to you for a given service or how you respond to them, right? So like I think a big part of the frustration of people who use drugs when it comes to engaging with traditional health systems is that in many instances, when they seek out services, it becomes a referendum on their drug use. They can go to the ER or urgent care or seek out help from a social worker or whoever else for a number of different things, and inevitably it will come back to their drug use, and often trying to get them to stop their drug use. And I think that is maybe the simplest way that we can make folks feel most at home and willing to engage in treatment when they come to see healthcare providers as people who use drugs. And that's just like listening to their needs on their terms, and then only bringing up drug use when it's something that the client feels is necessary. It's staggeringly evident to me, but I think like something that bears repeating is that if you build trust with people who use drugs, they will eventually talk to you about their drug use. It's a big part of their lives. In lots of cases, it is a problematic part of their lives as well, and they either want to stop or change their patterns of use or use more safely. But like if you as a provider of any services, whether you're a case manager or a nurse or a physician, if you just provide the space for a open dialogue with the client where they feel respected and heard, and if you want to address their drug use, eventually they will bring it to you, and you will be able to do so from a much better place of collaboration rather than springing this on them when they were really wanting to talk about a different issue in their lives. And one thing that we don't have time for necessarily on this call, and it isn't as related to drug laws, but I guess in a certain way it is sort of the reasons why people leave care. I've recently got an opportunity to do a panel with some syringe service providers about sort of barriers that they see their clients encounter in healthcare settings. And one of the big ones was sort of around lack of autonomy, and feeling almost infantilized in healthcare settings, as specifically hospital settings. Had one person talk about basically the idea that going to the hospital was kind of being reincarcerated, being trapped in a room where you're told you can't leave, you can't go outside to smoke a cigarette or walk around, where you're instructed to do things, and if you don't do them, you are chastised or punished. Oftentimes, and I personally, I had never thought of it that way, but I mean, it makes a world of sense when you put someone who uses drugs in a environment where they don't have their needs met, they don't have autonomy, and they don't have access to the drugs that they need to not get sick. It shouldn't be a surprise when so many of them leave before their course of treatment is done. And so I think another thing that we can be doing as providers is working to create environments where people who use drugs in inpatient settings, in inpatient hospital settings, have more say in their care, and more leeway to I don't know, like it seems like we have so many rules in healthcare that get in the way of our ultimate goals. I know this was the case in Philadelphia for a long time, but there was a rule there where if you went to inpatient treatment, you couldn't bring cigarettes or tobacco, and you couldn't smoke, and if you smoked, you got kicked out, right? And it's one of those things where it's like, yeah, I understand that tobacco cessation is important, and that we need to make sure that we're helping folks be as healthy as possible. But if the goals are to get someone sober, or to get someone on MAT, or to get someone to change their drug use, and the impediment is smoking or not smoking, it just seems like lunacy to say, well, okay, you're just not going to get treatment because you want to smoke. It's sort of one of those things where it's like we can deal with that later. One of these things is more immediately pressing than the other, and I think that's the case in a lot of spaces with inpatient care, where it's like, yeah, we have a lot of issues around drug dependency and other things, but if someone has a really catastrophic wound that's in danger of going to sepsis or whatever, like, it doesn't make sense to deny someone opioids or whatever the drug of choice is, out of some sense of getting them off of drugs, when that's not the main problem at hand. And so I think a lot of these things are internal policies. Some of them are based on federal and state laws, but by and large, I think with the better we will be able to serve people who use drugs, the best way, I think, is really by doing so in a collaborative manner, where they feel like they have some say over their standard of care. I don't know how long that was. I didn't practice the length. If it was entirely too short, A, I apologize, but B, we can also talk with questions probably for like 3 hours. So I am happy to take any questions that folks have based on the presentation. And if there aren't questions, I'll find something else to ramble about, I promise.
Drew, thank you so much. We really appreciate you and the content. And you know what? I think that's great that you left a lot of time for questions. We do have one question in the QA, but I will say that before I open that up, Drew has agreed that if we don't get a lot of questions in QA and you feel more comfortable, I see people raising their virtual hand. I'm going to go ahead and start with the QA pod, but we will open your line to allow you to speak, to say your question out loud, so that if you feel more comfortable with that, we'll give you that opportunity. So just starting with the QA pod, Drew, I'm curious, what other states have the Good Samaritan laws against decriminalization, knowing that the state of Maine presently has one?
So I believe, and I'm not entirely positive about this, but I believe that every state in the US has some form of Good Samaritan law. The biggest question, I think, facing people who use drugs and advocates now is both the strength of the individual Good Samaritan law and whether or not a death by distribution law negates anything within that law. So one instance I'm thinking about right now is I see we've got some folks on the call from Ohio. Ohio's Good Sam law isn't great. It basically, and let me know in the chat, folks, if I'm not entirely accurate with this, but I believe Ohio's Good Sam law basically gives you 2 strikes, or maybe even 1 strike. I can't remember which one, but 2 or 1 chance to call the authorities if someone is with you and they're overdosing, and to not have criminal charges pressed against you possession when they come to the scene. Like it's really it's not public health based. It's still incredibly punitive, and it really discourages folks from reaching out, because you have to think like, okay, have I called before? Are they even going to adhere to this law if they show up, if this is their attitude towards people who use drugs? And they also mandate that, I can't remember if it's the person who overdosed or the person who called, or both, but they also mandate that person go to treatment for 30 days. So like if you have a Good Samaritan law, but it's only applicable once or twice, and it also is conditional on you going to treatment and stopping drug use for 30 days, like that's not really doing anything. And it's not going to greatly increase the number of folks that are calling for help. Similarly, like in a state like North Carolina, where they have a Good Sam law that I believe is pretty decent. I mean, their death by distribution law undoes a lot of the good that the Good Samaritan law does. And we're seeing this across the country, where these laws are contradictory, and the death by distribution laws are winning out. So I would certainly investigate whatever your state laws are around Good Samaritan laws or death by distribution. But it's a patchwork. There's no federal there's no real federal law overseeing Good Sam laws in the U.S.
And a few people have mentioned some states and related to that in the chat. So for another question, any experience with fentanyl and HIV populations, young adults 23 to 33 years old in the California setting?
So I mean, I don't do direct service work. I will say that H United has a public policy council that has a number of members in California. San Francisco AIDS Foundation, APLA Health, LA LGBTQ Center, Desert AIDS Project out in Palm Springs. All of them work with young folks, and many of them work with young folks who use drugs, and fentanyl is increasingly prevalent in the drug supply in California. What I will say about the drug supply in general when it comes to fentanyl, and this is true in California and elsewhere, is that it necessitates more frequent injections or uses through smoking, if you're smoking the drug, than heroin or prescription pills do, because of the shorter half-life of the drug. So if you're looking strictly at like a situation where you're trying to measure risk for HIV transmission based on injection drug use history, it's going to be more likely, in all things being equal, with fentanyl than with heroin. And we actually saw this in Scott County, Indiana, back in 2015. If folks might remember the large HIV-related injection drug use-related HIV outbreak in Scott County, that was actually sort of grounded in use of Opana, a prescription opioid, that the way that it was being used and the way it was formulated, it required more frequent injection. And so that was part of what drove that crisis, in addition to the Planned Parenthood in Southeast Indiana being shut down and no one having access to HIV testing. But I would say the main thing for fentanyl in terms of people living with or vulnerable to HIV is just that knowing that injection drug pathway to transmission is going to be more fraught if they don't have access to clean syringes. Oh, and apologies, one more thing, especially for young folks that engage in chemsex, just have folks give out fentanyl test strips, if possible, to people who use stimulants who come to your facility. Just because I think what we've heard from providers and from people who use drugs and users unions is that in most parts of the country where there's fentanyl test strips don't really do anything for opioids, because people just kind of naturally assume that there's fentanyl in their drugs. And it doesn't tell you how much fentanyl is in there. And no one's going to just not use their drugs because it has fentanyl in them. They still need to get high. But I think in a lot of communities, we're seeing stimulant users who are opioid naive or simply just aren't expecting to have any sort of opiate in their drugs die of fentanyl overdose because the fentanyl has their supply's been contaminated with fentanyl, whether they're using methamphetamine or cocaine or anything else. So, I mean, I would certainly be really open with younger folks who might be engaging in chemsex or just using meth or cocaine or other stimulants, that there's a real chance that there might be fentanyl in their supply at some point. So handing out fentanyl test strips, making sure they're used with a partner that has naloxone, things like that.
So where, Drew, do you know of a good resource to find out what laws are in your state or locale?
So I know that I believe National Harm Reduction Coalition has a website that goes over each state's Good Sam laws, syringe service laws, and I think possession laws. I don't know it's on National Harm Reduction Coalition's website. I don't know what the title of it is, but also like just Google searching your state and those laws will bring up something, whether it's from like Kaiser Family Foundation has a good chart, or Center for HIV Law and Policy. Like there are lots of places that might have it, but Google's your best friend in this instance. So I think that might be just the best way to find it and just try to discern on your own if it's a reputable source. But that's what I would recommend.
Kind of along the lines of that last question, Drew, by any chance, do you know which states still have HIV criminalization laws or how many?
So we're still on screen share, right? With me. I am going to
Yes.
go off of screen share for a second. How do we see pause share, stop share? Beautiful. So while that is happening, I'm just going to find that chart for you and bring it up on the screen. This is from the Center for HIV Law and Policy. Oh, I wish they had a better graphic on this. Dang. Sorry for the mumbling. There we go. That's not awful, but it's decent. I will put this up on the screen now. And please don't pay attention to the number of tabs I have open. I realize I have a problem. It's like 25. My computer hates me. But this is a map of all of the states in the US that have HIV criminalization laws. So as you can see here, 34 have HIV specific criminal laws or sentence enhancements. There's a key. I'm just going to scroll down briefly so you can see the key down here. So 30 have HIV specific criminal laws, 8 increased penalties, and a number of things that happens that I think a lot of folks don't often realize is that people can be prosecuted under non-HIV specific general criminal laws for HIV, for transmitting HIV to a partner. This is really big. I know in Texas, like they don't have an HIV criminalization specific law, but there are a number of cases that we see, every year or so involving HIV criminalization that are using a different statute. So it is still much more prevalent than anyone would like, or at least we would like. But a lot of these states also have had laws that have been lessened in recent years. For instance, I believe Indiana recently changed their HIV criminalization law. They still do criminalize it, but it's much less draconian than it was, and the original law involved science and understanding of HIV from like the early 90s. So there are places that are making progress around this, but they still have still have laws on the books. But I would recommend using the U.S. Center for HIV law and policy for any information you want on HIV criminalization.
Thank you. And Drew, can you provide that link that you just showed in there's some interest in the chat. So if you could throw that in the chat.
Absolutely.
And while you do that, I'm going to throw another question at you. So xylazine, a new rising epidemic. Are there any laws being developed to address it? I'm not sure if you've addressed this, but that this came up a few times in the chat.
No, absolutely. So xylazine, we're in an odd place in that Congress is starting to try and schedule xylazine. There are a number of different proposals right now in Congress around finding ways to criminalize xylazine or research it. It's different than most drugs that we have encountered in the past because it's not scheduled, but it is a known drug. It's just a veterinary drug. Xylazine is a horse tranquilizer, or at least in its original usage. So it's already in abundance, and there are laws governing it. They're just around veterinary use. So it remains to be seen what will happen with the scheduling of xylazine. If xylazine is like any other drug that we've seen in the last 50 years, eventually it will get scheduled somewhere or temporarily scheduled. Our hope is that whatever drug schedule it goes into, that it allows for both significant research opportunities, so we can have a better understanding of how xylazine works in the body, and how to prevent xylazine-related wounds from forming, and also that it's not associated with any mandatory minimums and as few criminal penalties as possible. But I mean, if folks are not familiar with xylazine, just a really brief primer. Xylazine use started, at least in the context of drug use among humans. Xylazine use started in Puerto Rico back in the 1980s, and was largely confined to Puerto Rico and actually the Philadelphia area. For a long time, there were some Puerto Rican immigrants I guess they aren't immigrants, they're just Puerto Ricans who came to Philly. But some Puerto Rican folks living in Philly that brought xylazine to the city as an adulterant for heroin. It just never really caught on. It wasn't a good enough high to really justify increasing production. And actually in Puerto Rico, the xylazine use went up and then went down just because there wasn't a ton of interest. There was still a small population of folks that did like the drug, but for the most part, it didn't pass muster. The reason why xylazine is so prevalent in the drug supply now is because of the emergence of fentanyl. And fentanyl as a drug has a much shorter half-life than heroin or prescription opioids. And so drug manufacturers, for the most part, were looking for ways to stretch out the lifespan of their product to meet the desires of the community that are using the drugs. And one of the ways that they found to do that was by putting xylazine, this animal tranquilizer, as an adulterant into their drug mixtures. And that allows for the effects of the drug to last for a much longer time. I mean, the problem is that those effects are really harmful, and even beyond the xylazine related wounds that we're seeing that are absolutely horrific and aren't related necessarily to the injection drug site. So if you inject in your leg, like you could have a xylazine related wound or sore on your torso or your upper arm. Like it's not necessarily related to the injection site. But it also has folks that are nodding out for for a long time. And that places them at tremendous risk for a number of things. We've heard of people getting hit by cars because they're crossing the street or trying to cross the street and they nod out and they can't get out of the way, or people that are being, mugged or robbed or assaulted because they're in public and they nod out and they're just, not able to defend themselves for a long period of time. And as a commenter mentioned, xylazine also, isn't responding to Narcan. So that's another thing that really gets in the way of our prevention efforts. So that was a really long-winded answer to that question, but we're working on xylazine. Excited that folks are getting xylazine test strips in certain places. We're also hoping that the price of xylazine test strips go down because they're frankly prohibitive at cost prohibitive at this stage. But hopeful that helps.
Great, thank you. I'm going to give the opportunity to patients to ask their question. So I'm going to open their line. Patients, go ahead.
You're on mute if you're speaking, patients.
That's a good point.
Oh, I'm sorry. Can you hear me?
Yes.
Gotcha.
Oh, yes. I think you have actually answered my question, Drew. That had to do with Xelanin. So you had answered it. Thank you.
And I know no question was asked, but it brought up something that I just want to mention to folks about like how we get the drug supply that we have. I mean, a lot of this is, the topic of this conversation was how HIV drug law or HIV, how drug laws impact drug user healthcare. And the biggest way that they do it is by changing the drug supply. We don't have xylazine or fentanyl because communities wanted it. We have it because it was a response to prohibitionist drug policies, and it was an easier way for drug sellers and for traffickers to get the drugs into the country and still make a profit and avoid arrest. And with xylazine, a way of trying to mimic the effects of another drug that they're no longer using because it's not cost effective, right? It's similarly, we went from prescription opioids to heroin, not because necessarily people that were addicted to prescription opioids decided, hey, I want to go to heroin, but because we started cracking down on prescription opioid prescribing, and all of a sudden people that had been, addicted to oxys or perks or whatever suddenly couldn't get their drug and had to turn elsewhere. So like almost all of these new emerging drugs are just drug supply whack-a-mole. And there's something like after xylazine, it might be nitazene's next. It might be some drug that we're not familiar with, but like in a weird way, drug use and the sort of the drug economy is about as close as you get to unfettered capitalism in the modern world. Like if there's a way to make a profit in the environment, that's what drug will emerge. And so based on what happens with fentanyl and xylazine, we will almost certainly see something else new crop up. And it may be worse, maybe better, we don't know, but it never stops adapting.
I'm also going to open now Wink's line so they can ask their question. Wink, so you want to unmute yourself?
Sweet, thank you. Yeah, I'm a polysubstance user and advocate for myself and others. But I think what you're saying is definitely, and any healthcare provider should definitely listen to this man. That trust is totally key and will open a lot more doors for you. But I have a request. Can you guys make it easier for us as users to like find these meetings and you people and like allow your patients or clients the ability and knowledge to know that drug users unions exist and you can start them and advocate for yourself, if that makes sense?
No, absolutely. that's spot on, Wink. And I think like one thing that we need to do a better job of is of linking users unions and people that utilize the services of SSPs, community health centers, wherever else, with advocacy groups. Because I mean, like to your point, like a lot of folks just don't know. And unless you're seeking out continuing education credits, like you probably might not come to a meeting like this. So thinking about ways of like, okay, how do we make sure that these discussions are happening with directly impacted folks? So absolutely.
And just there's a question. Can you explain what are user unions?
So I mean, I want to, if Wink, if you're still on, just want to see if you want to talk about your experience with user unions. God, it's so
Oh,
hard to
sure.
say. And then I'm
I
happy
mean,
to follow up.
So yeah, I'm a founding member. I hope Bridget's still here. I don't know, but we're Wisconsin based. We're Pulse, promoting understanding, lifting stigma and empowerment. And we're totally in our infancy. There's only like 7 of us, but we all actively use substances to whatever degree. But I mean, there's people in harm reduction at our local syringe service. We have people in the Department of Health Services in Wisconsin, and we actually just got aligned with another group that is going to train us and make us become self-sufficient and become a nonprofit entity. But to me, it's just a way to advocate for our, so a drug users union, we're going to advocate for harm reduction, policy change. But you touched on that earlier, that like that's a whole nother fucking issue. But like I'm sorry, that's how I speak, I'm sorry. But yeah, it's just people who use drugs and allies to advocate for harm reduction and safe supply access.
What he said, but also like I think one way to think of a users union is to think of it as a collective, bargaining or an advocacy organization, people who use drugs who don't have other ways to speak with one voice. And a lot of times that can be in policymaking, but that also can be when it comes to speaking with local providers, or even with folks who are employed by a harm reduction organization. If folks feel like that they're not getting paid sufficiently, or their benefits aren't good, like it's a pretty wide catch-all of things that can fall under a users union. But I think the core of users unions is providing a space for people who use drugs to be heard, but heard as a voice speaking to power in a useful way, or in a more effective way. But thank you for that question.
And so we do have a lot of questions coming in, and we're going to try to get to them as much as possible. We are coming up to the top of the hour of when this webinar is scheduled to end. If you can stay on, we welcome you to stay on. Drew has agreed and to continue a few extra minutes, so we'll try to get through some more questions. But just to let those who need to drop off know that the link to the evaluation is in the chat, and we will be providing the recording and the slides, so you can see if you missed these last few minutes, you can go ahead and look at the recording. So I'm going to go ahead, Drew, and open Leslie's line and allow them to talk. Leslie, go ahead, and you want to unmute yourself.
Sorry about that. Just thank you for having this. It's been quite informative. Link Up Chicago, we have like a 3-year organization, and we're an advocate for persons, particularly meth users, currently or have in the past, and been an advocate and resource provider. So having these type of forums that become slide decks are been using as a learning tool to inform them and empower them on a proper use in the laws and the different sources. I use them as information, and when we go to clubs and with other church organizations who have been very open to allowing us in and just educating the community. So I'd say thank you for that.
Absolutely. And if folks are still on, I'm gonna put my email in the chat. It was on that last side, but it's dgibson@ageunited.org. If you have state or local advocacy issues around harm reduction or anything related to HIV, please feel free to reach out to me. I can't guarantee that we'll be able to help based on our bandwidth, but if I can't, hopefully I'll be able to forward you to someone who can. So please don't hesitate to reach out.
So just triaging some of the questions in the chat. Have you heard any issues of people run into with seeking clinic care? You spoke specifically about not being able to leave inpatient hospital to smoke or other things. Are there other issues you've heard specifically around clinic-based care, other than trying to address drug use during appointments that have nothing to do with that, like you said earlier?
I mean, I think those are really the key things is like the lack of autonomy speaks to why people are leaving. And so I think honestly a lot of this is having discussions with large hospital systems and community health centers about sort of how they structure their models of care to allow for people who use drugs to feel more comfortable and to try to avoid these types of absences. One thing that I recently read a study where they were talking about harm reductionists being brought in as part of sort of a broader consult team in inpatient clinical services that I think has some real promise in terms of like the idea was that you have maybe someone who's in the hospital for one reason or another, and then the clinical rotation might go. So you have the main doc come in, then maybe you have a nutritionist or wherever else, and then maybe after that you have like the oncologist if they have cancer or whatever, and then you have a harm reductionist who comes in and is someone from community, someone who's able to speak their language and identify and establish ready rapport with folks, and have that as a sort of bridge to care in the outside world. And I thought was really interesting. So I think there are ways to try and address this. It's just that our modern hospital structures and clinical settings really aren't designed for flexibility, much less flexibility for a population that's marginalized.
And could you talk about criminalization of people who give birth while they were using substances?
I mean, I do not have enough information on that to speak meaningfully to it, other than that it's absolutely horrifying. And that, you know, I think harm reductionists, people who use drugs, we certainly need to be in better dialogue with both reproductive rights advocates and just, you know, women's rights advocates and folks that are advocating for new mothers. The difficulties that women in our society encounter simply being able to raise their children because they are someone who uses drugs is absolutely unconscionable. We know that the outcomes for people who use drugs, that are mothers who use drugs who are able to raise their children, are so much better than they are for people that are thrown into foster care. Like these are all things that we need to be working on, and if that's an issue that's of great interest or passion to you, please reach out to me. I'd love to be more involved. Hearing too many stories of women who aren't able to be mothers, or men who aren't able to be fathers because of these prohibitionist laws.
So you've given this person a lot to think about regarding prohibition type drug laws, and they're curious if you can speak to ideally what do we want drug laws to look like to promote recovery?
Shoot. I mean, honestly, there's a lot of room for better drug laws currently. Like I would love to see broad decriminalization. of all substances. And I think the most important thing right now, and that we're so far away from getting, is getting regulation and standardization of drugs across the country. Recently, some folks from the Drug User Liberation Front in Vancouver were arrested for dispensing drugs, which they have been doing for a couple of years now, where they clearly labeled on the packaging what was in the drugs, tested it all, providing a safe supply for folks in the city. That's what we need. We need some sort of structure that allows for people who use drugs to have access to drugs where they know what's inside them. Like we act like we haven't seen this before, but this movie's happened. It was prohibition. It happened in the 1920s. It didn't work. People died from, rot gut and bathtub gin. And all of a sudden, when you start regulating those things, suddenly people aren't being poisoned by, ethyl alcohol anymore. And it's the same thing to a much greater scale right now with the current drug crisis, is that we have all of these deaths because people don't know what's in their drugs, and the drugs are far more toxic than they ever have been. And there's no way of regulating that so long as our government views it as something to be criminalized and punished.
And we'll just take two more questions, but the majority of people who use drugs don't actually inject those drugs, and a lot of people who use drugs only use them occasionally. What strategies can we use to expand harm reduction to that community?
So I think a big part of this, and the switch, especially on the West Coast, but I think everywhere in the country, from injecting to smoking fentanyl is hopefully driving this. But I think a lot of it is just how we brand and market services. Maybe at some point that involves just renaming and not talking about syringe services programs, but using a different name. And it could sound sanitized, like Drug User Health Hub or whatever else. But like we need to do a better job of doing community outreach and letting folks know that syringe services programs aren't just for people who inject drugs. And part of that might be a name change, but like harm reduction services can't just be centered on one mode of use. So I think that's something we have to work on internally, but I certainly think someone in the chat just mentioned safer sorting kits, safer proofing kits. Like we should be getting out to festivals and to regular events and going to community centers and saying like, hey, this is what we do, if it's safe for folks to do in their area, and just spreading the word from folks within those communities to say that these services are here and you can use them. Yeah.
So for that last question, because again, I know we are over time, it seems like there's a decent amount of the street economy around stimulant use has moved to apps like Grindr, chemsex, sex work, buying and selling, etc. But also there's been a push for vigilantes using Grindr to catch sexual predators. Is there any work being done to create safe spaces for queer community to commune sexually without policing, if you're aware?
Lord, I mean, I'd love to know if you thought like, yeah, I'm tangentially aware of those issues, but yeah, I can't speak to that, unfortunately.
Drew, thank you so much. We appreciate your presentation, the content, but also answering all these questions. I think it really gave us a lot to think about moving forward. I do. So thank you, Drew, and thank you everyone that participated today and that was able to stay over with us. We just want to say that the next session of our series will continue in December, on December 1st at 12 p.m. Eastern Time. It will be substance use and HIV among African American same gender loving men, issues and trends, and we welcome you to participate and again complete that evaluation, and we hope to see everyone next month. Thank you, everyone. Thank you, Drew.
Thanks, y'all.